Morning, everybody. My name is Lucy Turcott. I'm the Division Director for Pediatric Hematology and Oncology, and today I am very pleased to introduce Dr. Robin Williams for today's talk. Dr. Williams received her medical degree and completed her residency in pediatrics at the University of Iowa before coming to the University of Minnesota for her Pediatric Hematology Oncology Fellowship. She joined the faculty after her fellowship. And along with being our institutional children's oncology group PI, Robin also oversees our early phase clinical trials program. Her research focuses on improving therapeutic efficacy in hematologic malignancies, and today she will be discussing targeting the surrogate light chain to treat B-cell ALL, mechanisms of action, and resistance for a novel VPB1 directed antibody-drug conjugate. Thanks for being here, Robin.
And thank you so much, Lucy, for the introduction, and then everyone that's here to listen to my talk today. I really appreciate it. I am a longtime listener to this seminar and first-time presenter. So let's jump right into this presentation about this new directed therapy that I have been researching and excited to share with you guys. So the objectives for this seminar, I hope that I'm going to be able to demonstrate that there is still room for another immunotherapy against B-ALL. I hope to illustrate the efficacy of our VPB1 ADC. I'd like to examine some causes of resistance against our VPB1 ADC, and then hopefully, if there's still time, some future directions for this therapeutic target. So I'm just going to address the sort of elephant in the room, and that's the fact that actually B-ALL is a model of major success for treating pediatric cancer. If you go back to 1970, only 10% of children survived this disease, and this particular figure is now even a decade old, but still showing that with our most efficacious cytotoxic chemotherapy regimens that we can cure close to or slightly above 90% of patients. So I'm not really setting this up for why we necessarily need additional therapeutic entities for this disease. But part of it is that these are outcomes for patients that received, as I mentioned, cytotoxic chemotherapy. And B-ALL is actually moving into the realm and, again, is ahead of the curve as far as utilizing immunotherapy in the treatment landscape. And so a couple of major successes for this disease, both in the pediatric and the adult space, is one, blinatumomab. Blinatumomab is a bispecific T-cell engager. On one side, it has CD19, so it can attach to mature as well as B-ALL cells, and anti-CD3 on the other side brings a T cell in proximity to the offending cell and then kills in that mechanism. And not only has blinatumomab been shown to be very effective in the relapse and refractory setting, but now we're even using blinatumomab up front with cytotoxic chemotherapy agents in both infant regimens as well as standard risk and high risk pediatric regimens. And the adult side, I can't really speak entirely to whether or not they're implementing this yet, but there's becoming increasing data that in PH or Philadelphia chromosome positive ALL, that you can actually just use blinatumomab and a TKI alone to treat some patients. And then on the other side is this CD22 directed ADC antibody-drug conjugate called inotuzumab. Inotuzumab doesn't quite have the upfront therapy data that blinatumomab does, but we know absolutely for sure it's incredibly effective in the relapse refractory setting in both pediatrics and adults. And then in the pediatric setting, we're hopefully going to be getting our high-risk trial going again, in which we will be using inotuzumab upfront in therapy for this disease. So I'm just telling you right now that blinatumomab and inotuzumab are great, but I do feel like there are some limitations to this current immunotherapy for B-ALL. So let's go through those. One being the fact that there is a lot of intra and interpatient variability in antigen expression. And so a really good example of this came from a publication that came out in 2018 out of the Children's Hospital of Philadelphia. They looked at over 600 cases of pediatric B-ALL. Most of them were the de novo disease, but some of them were relapse disease. And what they found is 1 in 5 patients had no surface expression of CD22, which would really exclude inotuzumab for being helpful in those patients. And then although in this study, they didn't show any patients that were completely negative for CD19, again, 17% or almost 1 in 5 patients had at least 1% of their disease that was CD19 negative, suggesting that when you use a CD19 directed therapy, you could select for CD19 negative clones. There's also an issue with antigen loss in relapse. Among patients who have had CD22 or CD19 directed therapies, as well as among MRD being measurable residual disease or refractory disease, that there's antigen loss in those 2 locations. And one good example of that came out in this publication in Leukemia and Lymphoma in 2023, in which the authors looked at the incidence of CD19 negative relapse after patients had received CD19 targeted immunotherapies, either blinatumomab or I hadn't spoken about this, but obviously we target CD19 with CAR T cells. And almost a third of patients who did go on to relapsed with CD19 negative disease. And this was something that I had came across recently that was a little bit counterintuitive, but again, sort of gets at the heart of the fact that the 2 receptors that we're most reliant on are CD19 and CD22. And in this publication, they looked at patients who had only had CD19 directed therapies. And they asked among the patients that relapsed, what was the expression of CD19 and CD22 on that relapsed disease? And what they found universally was that patients who received CD19 only directed therapy lost expression or had decreased expression of not only CD19, but also CD22 on that relapsed disease. Another limitation to targeting things like CD19 and CD22 is that these therapies, these immunotherapies, are linked to infectious complications. And that's due to the fact that CD19 and CD22 are not specific for B-ALL. These are targets that are also on healthy, mature, circulating B cells. And so what you get is on target off tumor killing of mature B cells. And just looking at the package inserts for blinatumomab, in which demonstrates the side effects that all patients within clinical trials had experienced. 1/4 of all patients on clinical trials with blinatumomab had some infection, and some of which were life-threatening or fatal. And then half of patients that received inotuzumab within the clinical trials that were evaluated experienced some infection, some of which were life-threatening or fatal. And then lastly, chemotherapy and radiation continue to, those outcomes for 90% of patients surviving, those patients are not, they are surviving, but they're not surviving without late effects, without lasting effects related to that therapy that they received. And unfortunately, to date, we have yet to curtail these late effects because the current immunotherapies that we're using are merely able to be additive to that current backbone and are not replacing the standard of care cytotoxic agents. So really, if we had additional agents, maybe we could start to pull back on those cytotoxic agents that are so that induce survival, but truly do cause lasting effects in these patients. And then for me, sometimes the best way to see a need is to really go to an anecdote to realize that there are patients who still need more from us as clinicians. And so there's this patient, she was 19 years old when she was diagnosed with B-cell ALL. That was in August of 21. She, at that time, was in Chicago and treated treated per a pediatric-inspired adult trial. So she was treated by adult oncologists. Induction is the initial cycle that patients with B-ALL receive. And during induction, she unfortunately got a very severe fungal infection in her brain, due to mucor. And the way to treat mucor infections in patients is not simply with antifungals, but you actually have to do debridements. You have to clean out the dead and dying tissue. And due to these abscesses in her brain, it resulted in an 8-week delay in her treatment. And unfortunately, this particular patient had measurable residual disease at the end of induction, which is indicative that she has disease that is refractory to our conventional agents. This young woman ended up with residual permanent hemiparesis, or inability to really move half of her body because of the treatment she received for her mucor infection. She has urinary incontinence and she has other neurologic deficits that are ongoing. Unfortunately, this young woman also developed an isolated CNS relapse, so only disease around her brain and not in her bone marrow during treatment. Her local team decided to salvage this by using intensified intrathecal chemo and radiation therapy, and then continued her on her prior chemo regimen. The poor young girl then later had a second isolated CNS relapse during maintenance therapy. And at this point, her local team decided that she should undergo CD19 directed CAR T therapy for a definitive consolidation for her disease. So fast forward to 15 months after she received that CD19 CAR T infusion, she was moving from Chicago to Minneapolis, and that's when I met her. 1 week prior to her meeting with me, her local team in Chicago had drawn a peripheral blood clonoSEQ. This is a way of monitoring for disease through a DNA-based assay. And it takes about a week for these results to come back. So of course, she's in my clinic. I'm meeting her for the first time. The results come back and they demonstrate greater than 6,000 clonal cells in her peripheral blood, which is frank relapse of her disease. We did a few blood tests in clinic that day and noted that she remained in B-cell aplasia. So there was no evidence of circulating B cells in her peripheral blood, and then flow cytometry from her peripheral blood and then later from her bone marrow really did confirm that this was a CD19 negative relapse. So she continued to have the presence of CD19 positive CAR Ts, but was relapsing with CD19 negative leukemia. She was referred in consultation with my bone marrow transplant colleagues. We decided that her best next course of action was to go to hematopoietic stem cell transplant. But obviously we would need to first re-induce a deep remission, given her history of the severe mucor infection, which we obviously did not want to recur in her, and the residual sequelae she had had from that, her initial infection, as well as other sequelae from cytotoxic chemotherapy agents that she had had. We opted to re-induce her with inotuzumab monotherapy. As I mentioned, it can be very effective in relapse disease. And at the end of one cycle, we got her to only 0.2% disease in her bone marrow, but at this point, it was CD19 negative and CD22 negative. And so we still could not take her to hematopoietic stem cell transplant until she had no evidence of measurable residual disease, but we were sort of backed into a corner of not having any additional agents, targeted agents to use against her disease. So you think we need one more? All right, let's make one more. So let's expand the range of immunotherapies for B-ALL. So I've sort of talked about the things that I find problematic with our current CD19 and CD22 targeting. So what would be the ideal novel target for B-ALL? So that would be that would be something that's expressed in the majority of B-ALL clones. But something different than CD19 and CD22 is that we would want it to be limited to immature B cells in B-ALL and be largely absent or completely absent on mature B cells, healthy mature B cells. And so in order to do that, we went to sort of the developmental stages at which the majority of B-ALL is arrested. And so we know, based on lots of data, that tends to be somewhere between the pro-B and the large B, large pre-B stages of B cell development. So then if we look at sort of the receptors that are expressed on cells throughout B cell development, we're talking about trying to find a receptor on the surface of cells somewhere between these stages here. And what we landed on was the pre-B cell receptor. So as B cells are developing, they need a pre-B cell receptor that is ubiquitously expressed to help with signaling and survival during development. And then they'll later rearrange their B cell receptor into a unique one that is different from everybody else's. But the pre-B cell receptor is ubiquitous to all developing B cells. And so part of that pre-B cell receptor is this surface molecule called VPRE-B1. So let's talk a little bit more about this proposed antigen target, VPRE-B1. So VPRE-B1 is also known as CD179A, and it's a component of the surrogate light chain, which makes up, as I mentioned a minute ago, the pre-B cell receptor. And so the surrogate light chain is restricted to early B cell development. Like I said, yay, that's what we want. But it's also essential for pre-B cell receptor assembly and signaling, suggesting that even leukemia cells might want to maintain the expression of this pre-B cell receptor and its components to maintain survival. So if this is going to be our proposed target, does pediatric B-ALL express VPRE-B1? So we started this evaluation by interrogating the St. Jude Cloud database of hundreds of primary patient samples, looking at the VPRE-B1 mRNA expression in B-ALL, as well as other pediatric tumors. And what we found is that VPRE-B1 mRNA was highly expressed among B-ALL specimens, especially compared to T-ALL and AML, although there was some expression in those two pediatric cancer subtypes as well. And then we saw, as we would predict, no mRNA expression among solid tumors and brain tumors. So let's dig a little bit deeper. Yes, it is expressed in pediatric B-ALL, but how is that expression among molecular subtypes of B-ALL? So if it's really just restricted to one molecular subtype or another, it really would not be broadly applicable to utilizing it for multiple patients. And so we really want something that can help the most patients. And so here I have a few of these expression profiles throughout the talk. So red is really our highest expressors, white is sort of moderate and sometimes low expressors, and then blue is low to no expression. And as you can see here, there really is lots of VPRE-B1 mRNA expressed among the B-ALL molecular subtypes. And for maybe some of the clinicians in the room, it's not exclusive to the good prognostic molecular subtypes, such as hyperdiploidy or ETV RUNX1, but specifically, we also see it being expressed in hypodiploid, KMT2A rearranged disease, IAMP21, as well as Philadelphia-like disease. So mRNA expression is not the same as having a protein expressed on the surface of B-ALL. So the next step, the next place we went to is to ask, can we actually detect this protein on the surface of B-ALL cells? In order to do that, we used samples from a children's oncology group biology study. And we specifically chose these 36 samples, diagnostic samples, because we knew that they were from disease that was refractory. So all of these 36 diagnostic samples, we also had data that said these patients had an end of induction detectable disease of at least 1%. So we decided to, subdivide all of these 36 samples into 3 subgroups, again, sort of signifying those developmental stages of B-ALL. We had the pro-Bs that were CD10 negative, pre-Bs that were CD10 positive, and then pre-Bs that were the most developed, but not mature, of course, that were CD20 positive. And what we found was that all, except for 2 cases, did demonstrate surface expression of VPRE-B1 at diagnosis, and that there wasn't any difference in the expression among the 3 groups. So we further expanded this to checking for VPRB1 expression on 5 BALL cell lines, as well as 10 BALL PDXs. And we did note all of them express VPRB1, ranging from 13 to nearly 100%. So this really made us feel confident that VPRB1 is broadly targetable in BALL. So given the fact that we utilized diagnostic samples that we knew had residual disease at the end of induction, we also wanted to interrogate, if possible, whether or not that residual disease also maintained the VPRB1 protein. And so among the 36 diagnostic samples that we had, we actually did have 16 paired pre-treatment and day 29 samples, 7 of which were standard risk and 9 of which were high risk. And as you can see here, both at day 0 and day 29, the vast majority of the refractory disease at day 29 did maintain expression of the VPRB1 protein. So I hope I've convinced you that it's worthwhile to target VPRB1. So let's transform VPRB1 into a novel targeted therapy for BALL. So in order to do this, we had to start by engineering a humanized VPRB1 antibody. We did that by probing a library that consisted of synthetically constructed human antibodies. The probe that we utilized were these serobodies. They consisted of a functional IgG1 heavy chain paired with a VPRB1 sequence. We found 16 clones that had an affinity for VPRB1. And then we're able to narrow it down to a single clone that was then used to produce a recombinant IgG antibody. And then we confirmed the reactivity of this anti-VPRB1 antibody against a BALL cell line. But just because this antibody combined to its target, we needed to quantify some additional properties of this antibody to know that it truly would be appropriate to bring forward as an immunotherapy. So we started off that evaluation by using biolayer interferometry, and we were able to determine that this antibody has a small dissociation constant, which suggests that it has high affinity but low dissociation for its target VPRB1. We then wanted to know, is this antibody specific for its target? So we used dose-dependent binding of the antibody to either low or high VPRB1 expressing cells. And as you can see, there is a dose-dependent effect among the high VPRB1 expressing cells, suggesting that there is high specificity for VPRB1. And finally, we had to know if we could get internalization of the VPRB1 antibody once it was bound to its target. And so we used a intracellular fluorescence assay and determined that there actually was rapid internalization of the VPRB1 antibody once it was bound to its target VPRB1. And then we decided to test the antibody alone. And to do that, we took VPRB1 expressing BALL cell line, we incubated it overnight with VPRB1 antibody, and then stained for markers of apoptosis. And in the group that received no treatment, we did see some deaths. So about 8.5% of cells died overnight or were in the process of dying overnight with no treatment. And then that bumped up to about 15% in the presence of the antibody. That's okay. We did see increased killing, but what if instead of just having a VPRB1 antibody, would it be better to make a VPRB1 antibody-drug conjugate? And we decided it would be better, and that's exactly what we did. So we conjugated our VPRB1 antibody to chalekomycin, which is a potent DNA binding agent that induces double-strand breaks once it's in a cell. And this is what, when I go forward talking about VPRB1 ADC, is the molecule that we have constructed. So now we have what we feel like is our new targeted therapy against BALL. So we needed to test efficacy. And so we started that efficacy testing by looking at how the VPRB1 ADC affects BALL cell lines in vitro. And to do this, we did a dose response curve in which we added increasing amounts of VPB1 ADC against cell lines that were either BALL cell lines. And then we also looked at some negative controls of mature B-cell lymphomas, multiple myeloma, AML, and CML. And as you can see here, these are the IC50s for the BALL cell lines, and these were generally in range for being able to utilize this ADC in vivo with these cell lines. So they were sensitive to our ADC in vitro. Did a similar dose response curve for the VPB1 against BALL PDX models. We have 9 PDX models here. And again, generally, although there was a pretty wide stretch of IC50s, it was generally, these were generally sensitive to our ADC in vitro. So this felt like enough evidence to take this targeted therapy against BALL from the dish into an animal. And so we started this evaluation by looking at how well the VPB1 ADC can target BALL in an animal model. So we used NSG mice. We engrafted them with luciferase expressing NALM6 cells. NALM6, as I mentioned, was a pretty high expressor of VPB1. We treated these mice once they had engrafted with the leukemia on days 1, 4, and 7. And we treated them with either PBS, VPB1 antibody alone, or VPB1 ADC. And so as you can see here, the mice are largely grafted except for this one over here in the PBS group. And then we followed them out with BLI, serial BLI exams through day plus 81. And as you can see, aside from this mouse that didn't engraft in the PBS group, by day 15, there were no remaining mice in either the PBS or the VPB1 antibody group alone, and multiple remaining mice that were BLI negative in the VPB1 ADC treated group. And another way of looking at this, pardon me, is a Kaplan-Meier survival curve. And here we clearly are demonstrating a survival advantage for the mice that received the VPB1 ADC compared to the mice that got either PBS or the antibody alone. And so given the fact, as I mentioned, that there were several mice that still by BLI did not appear to have active leukemia, we euthanized those remaining mice at day plus 110, and we evaluated their bone marrow for evidence of BALL. As I mentioned, that cell line, or I was trying to indicate that cell line as a human BALL cell line, so it expresses human CD19. So we looked at the presence of human CD45 and CD19 among these mice, and there was essentially no leukemia in the bone marrow of these animals. It was equivalent to an animal who had never received any leukemia in the first place. So that's a cell line. How does our VPB1 ADC target BALL PDX models in vivo? So as I had mentioned or demonstrated previously, we had looked at the dose response curves for 9 PDX models in vitro. And so we went on to test 4 of these in vivo, but due to the time constraints for this talk, I'm only going to talk about B3 and B5. So for the PDX models, we only had 2 treatment groups, either the VPB1 ADC or PBS. The animals still received 3 doses of either of those on day 1, 4, and 7. They were dosed once they had somewhere between 1 and 5% circulating BALL. And that's going to be signified by the gray bar. And then we also evaluated leukemia burden in both the bone marrow and the spleen of these animals 2 days after the final dose of either the PBS or the VPB1 ADC. And so for B3, we did see a survival advantage for the mice that received VPB1 ADC compared to PBS. None of the mice were long-term survivors, but we did confirm that, again, 2 days after that final dose, that the animals that received the VPB1 ADC had a significant decrease in their leukemia burden in both their bone marrow and their spleen. And then for B5, which turned out to be a bit more of an aggressive disease, PDX in the PBS group, actually we demonstrated many animals that survived in the VPB1 ADC group. And given the fact that there were survivors at the end of the treatment course for these, we again looked in the bone marrow and the spleen of these animals at day plus 168 from treatment, and found again that in the bone marrow and in the spleen of these animals, there was essentially equivalent to the amount of disease there was essentially equivalent to animals that had never received any PDX BALL cells. So I'm hoping thus far that I have convinced you guys that VPB1 ADC effectively targets BALL cell lines and PDX models, both in vitro and in vivo, or maybe. So there's an asterisk next to the in vitro data, and that's because I didn't really hint on this, but let's sort of come back to it, is that there were two notable exceptions, and those two notable exceptions were a cell line called ALL 1807 and HALO1. As you can see, 1807 had a partial response, but not the same robust response as the other cell lines, and then this HALO1 had no response whatsoever to our ADC. And so just to make it a little bit more clear, because obviously there were a lot of other cell lines, including negative controls on the last one, you can see here, as I mentioned, NALM6 in this assay was very sensitive to the ADC. Here's ALL 1807 that was partially sensitive, and then HALO1 that was not sensitive at all. So let's go on a side quest and let's investigate some mechanisms of resistance. So we know that there are several factors that can influence a tumor cell's ability to evade a drug. And so let's start by talking about decrease drug uptake. So really, are these cell lines either partially responsive or not responsive at all to our VPB1 ADC, because they either don't express VPB1 or the antibody isn't uptaken, like I had shown previously, happens rapidly whenever VPB1 antibody is bound to its target. And in fact, that wasn't the case at all. We can see that HALO1 and ALL 1807 both express pretty highly VPB1, and both within an hour appropriately uptake the antibody once it's bound to its target. So despite their relative resistance, neither lack VPB1 expression or have impaired ADC uptake as being responsible for their resistance. So what about overexpression of drug efflux transporters? So what are drug efflux transporters? Well, these are multi-drug resistance transporters, and these are proteins that can be expressed at the surface on cancer cells, and they actively pump out drugs and toxic compounds out of the cell, leading to resistance to cancer treatment. And so the primary type of protein that is noted for these are these ATP binding cassette transporters, or ABC transporters. And one of the most widely known in cancer therapy or resistance to cancer therapy is the ABCB1 or P-glycoprotein, which I will call PGP for the remainder of this talk. And so again, going back to databases in which we can interrogate mRNA expression in primary samples, we were able to see that, in fact, PGP mRNA is expressed in primary BALL cells, many primary BALL cells. So is that what's going on here? So we tested the surface of both HALO1 and ALL 1807 cells for the presence of PGP. And lo and behold, not ALL 1807, but HALO1 does express PGP, or this ABCB1 protein. And then to demonstrate that actually this protein is functional on these cells, we labeled the cells or gave the cells calcine AM, which is a fluorescent PGP substrate. And so cells that take up the calcine, if they do not have an active multi-drug resistant pump, then they will have lots of intracellular calcine. And what we found was that Halo-1 actually efficiently effluxes the calcine, suggesting that not only does it have PGP expression, but it's also active. So if Halo-1 is resistant because of a multi-drug resistant protein, then we should be able to use a multi-drug resistant protein inhibitor to reverse the resistance that we're seeing. So we started this evaluation by looking at Tewiquidar, which is a third generation PGP MDR inhibitor. And cells were again treated with calcine AM, and then we monitored for efflux. And so again, on this side is the ALL 1807 cells, which there really was no change whatsoever in being able to see the calcine. But then among the Halo-1 cells, in which completely effluxed all the calcine previously, in the presence of Tewiquidar, this was blocked, suggesting that we were able to block the PGP protein that was causing resistance. So if we're able to block the PGP protein, will this now sensitize Halo-1 cells to the VPB1 ADC? And that was in fact what we saw. So again, this is Halo-1. This is the resistant Halo-1 with the functional PGP that we know that it has. And then in the presence of Tewiquidar, we were able to, the presence of Tewiquidar and the VPB1 ADC, we went from greater than 90% viability to less than 5% viability. And it had no effect whatsoever on the ALL 1807 cells, which you would predict because they're not expressing PGP. And the Tewiquidar itself is not what's killing these cells. As you can see, there's equal viability in the presence of Tewiquidar alone. So if the reason why Halo-1 is able to be resistant to our VPB1 ADC is because of PGP, then can we make cell lines that have either are very sensitive or partially sensitive to our VPB1 ADC resistant by overexpressing PGP. So we looked at NALM6 and we looked at the ALL 1807 cell lines with overexpression of PGP, and both demonstrated profound resistance to the VPB1 ADC when PGP was overexpressed. So this is NALM6 with PGP overexpressed, and up here is ALL 1807 with PGP overexpressed. And then when you treat those overexpressed cells with Tewiquidar, you regain the sensitivity that these cells had previously. And the sensitization is not just true for this drug Tewiquidar, but we actually also look at Suiquidar, which is another third generation MDR inhibitor. We chose this one as a second evaluator because there is clinical trials demonstrating that it's safe in patients and that it can improve efficacy with another ADC called gemtuzumab in elderly adults with relapsed and refractory AML who have disease that's positive for PGP. And again, pardon me. So the Halo-1 cells were refractory to ADC treatment, but in the presence of Suiquidar, they became sensitive. And the same was true for the NALM6 that overexpressed PGP and the ALL 1807 that overexpressed PGP. So this is one mechanism of resistance that can be overcome with inhibition. But unfortunately, this is, like I said, it is a side quest. It's very interesting, but it really only helped us with one cell line that was resistant. So additional mechanisms of resistance include things like anti-apoptotic protein expression, things like BCL2. So there are proteins that cells can express. One in particular is BCL2 that sort of helps the cell prevent death through apoptosis. And so in order to see, again, whether or not this would be a target for BALL, we evaluated whether or not, or how often primary BALL samples express BCL2. And in fact, it is highly expressed among many molecular subtypes. And it's not just, again, mRNA expression, but we went back to our cell lines, our NALM6, our REHs, and the ALL 1807, and identified the fact that all of these BALL cell lines do exhibit intracellular expression of BCL2. So we wanted to know, because there are BCL2 inhibitors, we wanted to know if we could synergize or improve the efficacy of our VPRB1 ADC with the addition of BCL2 inhibition. And so this evaluation, we used the NALM6, the REH, and the ALL 1807 cells, and we treated them for 48 hours with venetoclax, which, as I mentioned, is a BCL2 inhibitor, or we treated them with VPRB1 ADC, or we treated them in combination. And then after the single agents or the combination of agents with the cell lines, we measured viability. And then we used Synergy Finder to generate a 3D interaction landscape based on the ZIP model. And so in the ZIP model, scores that come out of that are 0 tend to indicate additive effect. And then ZIP scores greater than 0 tend to indicate synergistic effect, and it's greater than 10 is most indicative of synergistic effect. Synergistic meaning that the combination effect is greater than the sum of the individual events. And what we found is among all 3 of these cell lines, 2 of which we knew were quite sensitive to our VPRB1 ADC, and the last one that's partially sensitive to our VPRB ADC, all of them had synergistic ZIP scores to suggest that targeting BCL2 in addition to using our VPRB1 ADC could create more BALL killing. So the ADC is great. We've shown that it works. It can work in vitro. It can work in vivo against B-cell, against PDX models, against cell lines. But ADCs have some issues. Sometimes they're limited by internalization efficiency, payload resistant mechanisms, which we've already talked about, drug conjugate instability. So there are other ways to actually use VPRB1 as a target outside of the ADC platform. And that's exactly what we are looking to do. So we know that it's a good target. We've talked about why it's a good target, but maybe the ADC is not the only, or maybe there are better ways of targeting VPRB1. And so that could include a bispecific T-cell engager like blinatumomab or CAR T cells. And so as a proof of concept, thus far, we have been able to generate a surrogate BiTE in which we were able to bring together the anti-VPRB1 segment with an anti-CD3 segment. And doing so, we did some dose response curves in vitro, looking at how well the T cells in the presence of this surrogate BiTE could kill leukemia, and did actually see a reasonable, although not the ultimate best outcome, but definitely saw a signature that this could be another way of targeting VPRB1 and BALL. So antibodies that are good for antibody-drug conjugates are not always the best antibodies for generating BiTEs, things like BiTEs and CAR T cells. So we think we might need to optimize the antibody that we're using. In order to do this, we have already sent off our recombinant VPRB1 antibody to immunize llamas to come up with some novel nanobodies to potentially replace the current VPRB1 antibody we're using. And then additional steps. So one thing I sort of hit on at the beginning of this talk is that I felt like that the reason why we needed an additional immunotherapy is because the ones that we have currently are leading to infections that are also decreasing the survival outcomes for our patients. And so the one thing we have not yet gotten to, but hope to very soon, is to really quantify the B cell sparing effect of our VPRB1 ADC. We've done very small experiments in this direction in which we looked at, in which we incubated peripheral blood mononuclear cells with the VPRB1 ADC versus PBS, and largely saw that there was minimal toxicity, but obviously this is just an in vitro assay and not the same as putting this into an animal or into a person. And so we hope in the coming months to be able to bring to fruition hematopoietic progenitor cell and PBMC humanized BLL PDX mouse models, in which we would use either PBMCs or HPSCs to humanize mice. We would then give the mice the BLL PDX models, and then also treat them with our VPRB1 ADC, like we treated these mice here with blinatumomab, and then serially check and see what happens to the B cells in those animals. So, in summary, I hope that I have been able to show you guys that the VPRB1 ADC that we have derived has potent anti-leukemia activity in vitro and in vivo and across a range of BLL cell lines and PDX models. I hope you'll agree that we've identified some mechanisms that enhance resistance against our VPRB1 ADC, by not all, but some of the clones, and that we truly are working to sensitize these cells as a means of enhancing this enhancing the therapeutic efficacy for the VPRB1 ADC. We are actively pursuing, or we've demonstrated that we're actively pursuing alternative immunotherapy platforms to target VPRB1, and that we hope that we'll soon be able to do the proposed studies to test the VPRB1 targeting agent on mature B cell repertoire and show that actually we do spare healthy B cells in patients receiving, or patients who could receive, this immunotherapy. So I would not be able to have this talk today if it weren't for Dr. Winter and Dr. Gordon, who have so graciously shared this project and allowing me to go forward with this project, and hopefully at some point bring it to the clinical realm. I want to thank the folks in Peter and Mai's lab. I also want to thank Joe Moretta and his lab for all that they've been doing to help us on the front of the nanobody front, and then others who have contributed to this work. So I thank you all for listening to my presentation today.
That's great. I've got microphones for anyone with a question. Just raise your hand.
Thanks. That was really interesting. I have a question that may be a little naive from like the bench side, but for patients, is there like a standard like testing panel after diagnosis that you can to like sort of really characterize the disease and look for things like the PGP and BCL2 maybe on top of the CD19, CD22?
Right. So there is some standardized things that we check for, some surface receptors, but it usually doesn't check for things like VPRB1. BCL2 is usually not evaluated either. We can sort of drill down and look for other mutations that as far as the molecular characterization, these are things we definitely could look for in a patient, but it's not standardized.
And is it all flow-based, not like a...
So some of it's flow-based, and some of what we're doing is DNA amplification. Yep.
So really interesting, Robin. I have a couple questions. One is VPRB1 and the pre-BCR required for maintenance of B-ALL cells. In other words, if they lose expression, is it bad for the ALL the way it's required for normal pre-B cells to survive?
Right. So there are B-ALL cells that don't express pre-B cell receptor. So it is not required for but by and large, it helps survival. And so I think that's why it's so maintained across so many clones.
The second question actually is related to this. You showed various bits of data throughout the talk showing that the percentage that were of cells in any one case, cell line or PDX or primary cells, for pre-B1 could be like 60% or 70% of the cells. But then you would show data with that sample, you treat with the ADC, and nearly all or all of the cells died. So I'm confused. If not all of the cells are positive for the marker, how are you killing them all?
Right. So I think some of it is there might be receptors there that don't necessarily get picked up on flow cytometry. So if you have a very low percentage of expression, you might still be expressing it. And by our thresholds for flow cytometry, we're just not seeing it. And so, yep.
Enough to be killed still.
Yep.
Yep, really nice talk. I'm just kind of interested in the beginning. I think you hinted that as cells become CD19 and 22 dim, presumably in response to targeted agents,
yep.
They become more dependent on the BTA pathway, which I think presumably links to one expression, right? So do you see those as being sort of synergistic in combination, CD19, 22 targeted agents with this one, or do you see enrichment for these clones that could then be targeted sequentially?
Yeah, that's a great question. I think we're still a little early as far as like how we would utilize it in the clinical setting. I would, I guess, not know how to suggest that just yet, because I think either would be realistic ways to target this. So.
Sure. I guess one other question, sort of in adults, ALL, Charles group knows that more in patients as they cells. So what we're seeing, chemotherapy resistant cells, myeloid stem cell state, which predicts they might not be as responsive to some of any of these B cell agents. But I'd be interested to see if those are still pre-B1 expressing, even though they seem to be 19, 22 negative.
Yeah, that would be really interesting, especially the fact, like I said, there is mRNA, VPB1 mRNA expression even among some AMLs. And so, I mean, I think maybe that's getting at what you're sort of suggesting is that, yeah, maybe we could still see that expression even in disease that has gone more towards the myeloid lineage and away from the lymphoid lineage.
Nice talk. I'm wondering whether the PGP1 expression is correlated to the VPB1 expression, like where you saw the positive outcome from the in vivo data. Do those cell lines still express some level of PGP1? It's like completely absent. I may have missed it. So what is the correlation between the VPB1 expression and the PGP1 expression? They're like inversely related or what?
So you're asking, in which cells expressing VPB1?
Yes, like where you have like positive data from the in vivo experiment, do those cell lines still express PGP1 or they're like completely absent?
So in the cells that are outside of the Halo-1 cells, are you specifically talking about Halo-1 cells, which
no,
we
these
know
are like non-responsive cells, right? Where you saw the responsiveness, like those cells expressed a PGP1 or not? I did not see those data. Like
yeah, so we haven't. We do plan on looking at PGP expression following treatment. I think that's what you're asking about. We have not done that. We haven't done that analysis yet.
Yeah, so the two cell lines, they overexpressed the PGP1, right?
Yep.
Where you saw the responsiveness, you did not check the PGP1 expression. That's what you're saying.
Afterwards, we did not do protein expression for PGP1. Exactly.
And the second question is that, do you have any kind of CAR-T data on this proteins or still BiTE?
So we have tried, and the sequence that we use for the ADC was not effective as a CAR-T. Okay. Yep. Which is again what pushed us to make to work on the nanobody sequences.
What is your thought, like why the CAR-T cell did not work, even if the same antibody?
Why didn't it work?
Yeah.
Great question. Like I said, I think it might be just the fact that the way in which that antibody functions as an ADC versus how it functions as a CAR sticking out of a cell. There's just different binding characteristics that wouldn't be the same as what I sort of showed as far as the dissociation constant and those kind of things. And so I think we just need a different way of targeting B3B1. Yep, in that setting. Go ahead.
Nice talk. What about the VB-Pre1 expression in the relapsed tumor after CD19 targeting CAR-T to the BALL patients?
So are you saying?
So if you are proposing your strategy to be an alternative for CD19 CAR-T, or it is going to be a primary therapy based on the VP-Pre1 expression data from the patients?
Yeah, so I think this is sort of getting back to what Sean was asking as well. I'm not quite sure where we would put it at this point. If it would be sort of, is this something we would want to target in patients that have already had CD19 and CD22 directed therapies? Or if we used it sooner, could we prevent those relapses? It's probably a combination of both, that the more things we target at once, the more likely we're going to eliminate all of the clones versus sort of pigeonholing the ones that don't express these things into surviving and then growing out. But I don't think this data is mature enough to know where it exactly fits.
So my question is about how these cells die when you treat them with the ADCC. Do you know anything about the type of cell death that you're inducing? So some types of cell death are very inflammatory, and others are not. And if they're not, the question really would be, would this potentially benefit from like a checkpoint inhibitor or something like that?
Sure. Great question. And I don't have any data on that at this point. Yep.
All right, do we have any? Mr. Williams?